This is chapter 14, care of the preoperative patients. The preoperative period begins when your patient is scheduled for surgery and ends at the time of transfer from surgery, into the surgical suite itself. The nurse will function as an educator and advocate, a promoter of health and safety as well. For surgical patients, there are new quality measures such as a wrong site surgery, patient falls, hospital-acquired pressure ulcers, and catheter-associated infections, those such as portacath, PICC lines, Hickman catheters, that must be reported to the CMS, the Centers for Medicare and Medicaid Services. All of this data is used for tracking patient outcomes, and if they are found the hospital liable that those particular issues happen within sight of the hospital, then a lot of insurance companies will not pay for those specific surgeries. So it is real important that all of these quality measures that the surgery centers and the hospitals have started to follow. It's important that they continue to follow all of their normal protocols. Some reasons for surgery: diagnostic, that determines the origin and cause of the disorder. Things like a laparoscopy, that patients are having abdominal pain, they don't know where it's coming from, the surgeon may go in there to look. Curative, to resolve a health problem by repairing or removing the cause, things like gallbladders, appendix, some types of tumors. Restorative, improves patient's functional ability. The patient may have a blockage somewhere and they can go in there and remove the blockage, and that will improve the functional problem that they were having. Palliative care relieves the symptoms of disease process, but it does not cure. A lot of cancer patients have palliative care to remove different types of tumors and masses, and sometimes parts of the colon, just to help relieve those symptoms, but they will still have their disease process. And then, of course, cosmetic, that alters or enhances the personal appearance, facelifts, liposuction, breast reductions, or enlargements, or those types of things. Y'all, I'm sorry, I had a finger slip there, so you may see a couple of different slides before you actually get the correct slide. SCIP stands for Surgical Care Improvement Project. This is a result of the Joint Commission and other agencies. They have developed this plan of care, and it helps to reduce and eliminate preventable surgical complications, and this is known as the SIP program. It focuses on infection prevention, prevention of cardiac events, and prevention of VTE, which is venous thromboembolus, also known as deep vein thrombosis. There are 10 specific core measures that have been identified, and all of these help prevent one of these 3 core measures. If you look on the table on page 217, it lists all of the 10 SIP precautions. Some of them are things like giving the patient a preventative antibiotic approximately an hour before surgery, making sure patients have appropriate hair removal, not necessarily the patient's removing it, but it being removed prior to the surgical process. Temperature management, making sure all the vital signs are within normal limits. This is a real important new one, that patients who are on a beta blocker should always have that particular beta blocker the day prior to surgery, the day of surgery, and after surgery. They no longer have the patients hold that particular medication, and then you can read through the rest of them. But these are just some of the processes that majority of the hospitals go through now to make sure that these patients come out of surgery feeling well and doing okay. Urgency, degree of risk, and extent of surgery. Urgency, whether it is an elective surgery, again, facelift, breast enlargement, whether it is urgent, Patients had their leg sliced open, they need to go in there and fix it. And of course, emergent, those that have been in trauma situations that maybe have internal bleeding. Degree of risk, whether it's minor or major, and extent, simple, radical, minimally invasive. Anxiety interventions. Preoperative teaching is very important to do prior to the day of surgery. A lot of physicians do not do this, or a lot of doctors' offices, but it is very helpful if you can sit down with that particular patient, let them understand, what kind of surgery they're having, what kind of things that may be expected of them after the surgical process. If they're going to be needing to use an incentive spirometer, then maybe teach them how to use that incentive spirometer, or how to do the deep breathing, or splinting, for example, which we'll talk about shortly. If the patient is more aware of the things that they're going to need to do, they're going to be more focused prior to that surgery than the day of surgery, where their anxiety level is extremely high. Encouraging communication, always ask open-ended questions to get the patient to speak with you about their anxiety, what they're thinking about, and always make sure that they don't have any last-minute questions. Some signs and symptoms of anxiety include anger, crying, restlessness, profuse sweating, an increased pulse rate, palpitations, sleeplessness, diarrhea, and urine frequency. So we always want to try to make sure our patients are at peace with this surgery, that they have all of their questions answered, because this can affect the patient's ability to learn and cope and to understand the teaching that we are trying to explain to them. And also, anxiety can also influence the amount and type of anesthetic needed, and it can also slow the recovery time. Always promote rest. If your client feels like maybe they need something to help them sleep the night before surgery, a lot of surgeons are willing to do that. Use distraction. Music therapy is really good for this type of thing. Maybe reading if they like to read. And then always teach the family members if they're willing to learn, so that because your patient may be a little more anxious, the patient's family will remember and can help them after the surgical process. Skin preparation. Any break in the skin increases the risk for infection, so we want to make sure that our clients that are preparing for surgery don't have any open breaks in the skin, haven't cut themselves lately. If they do, then the surgeon is notified of this. Patient may be asked to shower using an antiseptic solution. HIPAA is one of the newer solutions out on the market, and basically the patient will clean with the HIPAA the night before. You turn off the shower, you clean the area, you clean your entire body, but you specifically clean the area that will be operated on. You turn the water back on, wash it off, and then you will do the same thing again in the morning time. This helps to remove the normal bacteria that's on the skin and get your area prepared for surgery. Hair removal by electrical clippers or depilatories. This is not necessarily for the patient to be doing at home, but the surgical staff may do this the morning of surgery. Because the shaving of hair does create a risk for infection, it's important for the patient not to be doing this themselves. Preoperative medications that may be used for surgery. Anxiolytics helps to reduce anxiety. Those are medications such as Versed. Sedatives and hypnotics promote relaxation. Ativan, which is lorazepam, Valium. Anticholinergic agents reduce nasal and oral secretions. If you've ever heard of a scopolamine patch, it's placed right behind the ear. It's used a lot with oncology patients, but it helps dry up the oral secretions, which can help prevent the laryngospasm and reduce the secretions that you may have. Reducing vagal-induced bradycardia, H2 histamine blockers inhibit gastric secretion. Tagamet and cimetidine are two of those. And then opioids, any type of morphine, Dilaudid, decrease the amount of anesthesia that the patient will need for induction, therefore not having to keep them under anesthesia for so long, and helps maintain their status. History and data collection. It is very important prior to a patient going to surgery that a complete history and physical is done. This may be completed at the physician's office. The physician may dictate a note prior to the surgery, and it needs to be complete. Age, height, weight, allergies, medications the patient is currently taking, surgeries that they've ever had, any type of anaphylactic reactions or any type of reactions at all that they need, blood donations, discharge planning, complementary or alternative practices. So it needs to be extensive. One thing that is extremely important for a physician to know is if a patient is on any type of herbal or supplemental therapy. Some of these medications do not do well or mix well with other meds, and because they've not been tested by the FDA, the physicians don't know how so well they would do with surgery. So it's important for the physician to know and for them to stop those medications prior to surgery. Physical assessment and clinical manifestations. Always want to obtain baseline vital signs. If you have any abnormality, of course, the physician will need to know that. Want to focus on any body systems identified in history, all body systems that will be affected by the surgical procedure, and if they're having any specific other problems with those body areas. Report or abnormal assessment findings to the surgeon or the anesthesiology personnel immediately. This way, as a nurse, you are being proactive, you're advocating for your patient, and this also lets the physician know if there's anything they need to be looking for after surgery, if it was a problem prior to surgery. System assessment. Cardiovascular system. You want to make sure a patient has a present history of coronary artery disease or a myocardial infarction within 6 months prior to surgery. They may want to do, additional EKGs or additional testing prior to scheduling that surgery. Patients with hypertension, which is very common, sometimes it's undiagnosed. It can affect the response to your surgery. We want to be listening to the patient's heart and lung sounds for a regular rate, any type of abnormalities. And we also need to know if the patient has ever had a DVT. You'll be examining your patient's skin, hands and feet for temperature and color. Of course, our normal assessment, capillary refill, edema. Anything that is absent or abnormal, again, is reported immediately to the surgeon for further evaluation. The respiratory status, we have to look at if the patient has any chronic respiratory problems, COPD, CHF, smoking history, including any exposure to secondhand smoke, any chronic illnesses. If you have an obese patient, they can have undiagnosed respiratory problems such as sleep apnea, and that can lead to complications from anesthesia. Observe your patient's posture, respiratory rate, rhythm, overall respiratory effect. Notice any clubbing of the fingernails, swelling, auscultate your lungs. So you can see how important it is to make sure we really assess our patients prior to surgery. Hopefully the physician has done this in the office within a week or two prior to the surgery, but it is also important for us as nurses to do this the day of surgery. The kidney and renal impairment can inhibit drug and anesthetic excretion, especially in our older individuals. If kidney function is altered, your fluid and electrolytes can also be altered. So a lot of times, or most of the time, the patients will have lab work prior to the day of surgery. Neurological status need to be determine a baseline, what their cognitive function is, if they're alert and oriented times 3 or 4. Patients who have dementia or Alzheimer's, we need to make sure that we have a baseline, that their ability and they have the ability to follow commands. Muscular skeletal, examine that particular body system. Any type of problem can interfere with positioning during and after surgery, so the physicians would need to be aware of that. Patients with arthritis may be able to assume some but have discomfort after surgery from prolonged immobilization. So we also need to look at neck and shape of our chest cavity. It can interfere with respiratory and cardiac function, or can require special positioning during surgery. And then just again, the psychosocial, how are these patients doing? How is their anxiety level? How is their nutritional status? Nutritional status can increase surgical risk. It can make the healing process a lot slower. Surgery increases your metabolic rate. It depletes your potassium, vitamin C, and B vitamins. All of those are needed for wound healing and blood clotting. So if you have a poorly nourished patient, your protein levels slow recovery. You can also have a negative nitrogen balance from the depleted protein stores, and this increases the risk for skin breakdown, wound healing, and possible dehiscence. Some older patients can have poor nutrition because of chronic illness, diuretic or laxative abuse, or just poor dietary habits in general. So laboratory assessments that may be useful, urinalysis to make sure that the kidneys are functioning properly and that there's not a bladder infection. Blood type and cross match in case that they need blood during the procedure. CBC or hemoglobin level, make sure they're not anemic and that they have enough red blood cells for the procedure. Clotting studies, electrolyte levels, creatinine test, pregnancy test, chest x-ray to make sure the lungs are expanding well, and then of course an EKG for cardiac function. Informed consent states that the patient is aware of the surgery, understands the risks and benefits, and is in agreement to the surgery. Technically, the surgeon gets the consent signed prior to the surgery and prior to any sedation. Us as a nurse, I apologize. As a nurse, you clarify the facts. You do not give them prolonged explanations. You just basically, you can re-explain what the surgeon has told them if they have something wrong about it, but you are not expected to explain the surgical procedure to them, explain any detailed information. You just clarify. We can verify that the consent form is signed, and we can serve as a witness to the signature, not to the fact that the patient is informed. I will tell you right now, a lot of the times we as nurses are responsible for getting the consent signed, but we must ask the patient, has the surgeon been in there to speak with them, and do they understand the procedure? Patients may sign with an X for those older patients that may not be able to write their name. We can also get a telephone authorization. You must have a second nurse listen to that telephone authorization, and both of you must sign the permit. And then there are some special permits required for some procedures. If a patient needs blood, then that is a separate informed consent that they must sign. And then well, that's it. I'm sorry. Okay, dietary restrictions. NPO means a patient needs to not ingest anything by mouth for 6 to 8 hours before the surgery. The majority of the time, the surgeon will tell them nothing to eat or drink after midnight, especially if their surgery is in the morning time. This helps to decrease the risk for aspiration. It's a good idea to give a patient's written and oral directions to stress adherence and to decrease their anxiety. Realize that surgery is a stressful time and the patients may not be really hearing what you are telling them. Surgery can be canceled if the instructions are not followed and the patient either drink prior to their surgical time. Administering regularly scheduled meds, that will be up to the physician as far as what he wants your patient to take the day of surgery. Again, like I said, if the patient is on a beta blocker, they will need to take that particular medication to help keep them from having any heart arrhythmias. Drugs that are often allowed with a sip of water, any type of a cardiac drug, respiratory disease, seizures, and hypertension is just, again, another reason why the physician needs to know exactly what that patient is on and whether they want them to take those specific medications. Exercises and equipment that the patient may be using after surgery. An incentive spirometer, which allows the lungs to expand a little bit better. TED hose, which helps patients decrease risk of DVTs as well as the SCDs. Splinting, especially for patients who have had abdominal surgery, the splinting works really well. They can take a pillow and put it up against their abdominal area, and that it will not allow any harm to come to the incision, but it allows it to be a little bit more comfortable for the patient to cough, and it helps to provide support and provide a feeling of security. Turning, cough, and deep breathing, we all know about that. There are some surgeries such as appendectomies and hernia surgeries that the physicians do not want them coughing because it can actually harm the incision area, but the physician should let the nurse know if that is the case. Intestinal preparation. This refers to things like enemas or laxatives. You generally see this with abdominal surgery, some colonoscopies, any type of bowel surgeries. The physician will have the patient do an enema or a laxative to clean them out, and then they can see things better inside there. And it also prevents injury to the colon, and it reduces the number of the intestinal bacteria. So patients that are at risk for VTE or a deep vein thrombosis, of course, as always, your obese patients, those that are age 40 or older, any patient with a history of cancer or with decreased cardiac output, decreased mobility, immobility, spinal cord injury, previous history of blood clots, pulmonary embolism, which is a blood clot to the lung, varicose veins, edema, previous history of oral contraceptives, smoking, and then hip fractures or total knee or hip surgeries put the patient at an increased risk. Preoperative chart review. Before your patient goes to surgery, you will need to run through the entire chart, make sure that all documentation, history and physical, preoperative procedures, if there are anything the patient is supposed to have prior to surgery like enemas, laxatives, and antibiotic, that all of those have been complete. Most units will have a pre-op checklist that must be initialed prior to the patient going to surgery. If the patient is having a procedure that is a laterality incidents like left to right arm or left to right leg, then you need to make sure the anesthesiologist or the surgeon has marked that particular appendage. Document allergies, height and weight, and ensure all laboratory and diagnostic tests are in the chart. Any abnormal results are noted and that the physician is aware of them, and also that those have been taken care of. If they're hypokalemic or hyponatremic, then those particular electrolyte imbalances need to be fixed prior to the patient going to surgery. Patient preparation. Want to make sure the patient removes most of their clothing, provide a gown. If the surgery is from the waist up, a lot of times the surgical staff will let them keep their underwear on and possibly cotton socks. Valuables need to be locked up with the family or locked up at the station. If they can't be removed, tape the rings in place. Ensure a patient is wearing their identification band and also an allergy band if they have allergies. All dentures, hearing aids, prosthetic devices, contact lenses, fingernail polish needs to be removed because a lot of times the O2 sensors will not pick up the O2 with the fingernail polish. Patients do not need to have artificial nails, and all jewelry needs to be taken off. So we have talked a good bit about how as patients age, their surgical risk factors and a lot of their factors are different. So for our older adults, they have a decreased cardiac output and peripheral circulation, which is a risk for surgery. Their blood oxygenation, vital capacity is lower. And then, of course, the blood flow to the kidneys affects the GFR rate. They can't filter out things through their kidneys like a younger person would, so the drugs stay in their system a lot longer. They can have increased blood pressure, of course, risk for skin damage and more so for infection. Sensory deficits. You want to make sure that that you are orienting the patient back to their surroundings frequently. They have a slower reaction time, so allow extra time for teaching this particular patient. Strict INO needs to be monitored to check their overall hydration rate and monitor electrolyte statuses. Assess frequently for their toileting needs, especially at night. Assess this patient's mobility, teach turning and positioning, encouraging ambulation so that we're not worried about skin breakdown. Of course, every patient needs to be on fall preventions, and of course, their skin is a little more dry and they have a lot less subcutaneous fat, so again they're at greater risk for skin breakdown. And then they have deformities related to osteoarthritis, osteoporosis and arthritis. Chronic illnesses, especially lung illnesses, these patients are more malnutritioned, so always again check their albumin levels. Impaired self-care ability, we want to make sure that as these patients are going home that they hopefully are living with someone or have family that can care for them. That fits also under their inadequate support systems. Their bodies are under more stress from the surgery and anesthesia. They are at increased risk for cardiopulmonary complications after surgery, so these patients will be needed to be monitored more frequently. Mental status changes, again, that falls under the reorienting the patient frequently, and of course the risk for falls. Well, that is the end of Chapter 14. Make sure you look over your review questions and case studies. They will help you study. Thank you.